research on June 30th in order to focus on COVID-related work. And today, Vivek is a member of the COVID-19 Immunity Task Force, scientific advisor for CanCOVID, which is the national research platform for COVID-19 research. I also want to highlight that Vivek's own research has focused on health services evaluation and the promotion of the use of research evidence in health decision-making, and hence he's a great speaker for today's talk. A little bit of his background: he's got a medical degree from McGill, postgraduate medical training from U of T. He has an MSc in community health from U of T and MS in biostats from Harvard. He also was the founding president and chief executive officer of Public Health Ontario. So it's a pleasure to have Vivek. It's a real honor and it's a privilege for all of us to have you speaking to us. I had a look at your slides and I'm very excited about the talk. Before I hand it over to you, I'm going to introduce the two discussants at this point so we don't have to come back to me. Greg Marshaldon, a close colleague in IHPME, is our faculty discussant for today. He is the Ontario Research Chair in Health Policy and System Design. He has a cross-appointment at Dalla and at the Monk School of Global Affairs and Public Policy. Greg is also the director of the North American Observatory on Health Systems and Policies, and he has published very widely on aspects of comparative health and health systems. Greg was, one of the things of note about Greg is that he has had senior positions in government, including serving as the deputy minister in Saskatchewan, as cabinet secretary and deputy minister to the premier from 1996 until 2000. Also of note, he was the executive director of the Royal Commission on the Future of Healthcare in Canada, also known as the Romano Report. Thank you, Greg, for being with us today. Finally, our student discussant today is Daniel Eisencraft-Klein. He was a member of the Clever Specialization last year and I think the year before. He is a PhD candidate in the Dalla School of Public Health, and his research is situated at the intersection of political economy and public health policymaking, with a particular emphasis on commercial determinants of health and substance use. So that's the group for today. I'm now going to hand it over to Dr. Vivek Goel for his keynote speak.
Thank you, Rob, for the introduction. And it's great to be here. I'll just get my slideshow started. And everyone sees the full screen?
Yes.
Okay, great, thanks. So it's great to be here for Public Health Policy Rounds. I was part of the original group of faculty when the program first got its CIHR funding with Joanna Cohen and Rob in the lead. And actually one of the pieces I'll present is from one of the inaugural fellows who took part in the program. So it's always a pleasure to come back and work with you. I'm going to be talking about the role of science in policymaking during COVID-19, and I really look forward to the discussion. Just by way of the background here on this slide, it's hard to find this particular view on campus anymore because there's another big building in front of it, but that is the original School of Hygiene building that was built in around 1927. So just under 100 years ago. And it's worth remembering that the whole School of Hygiene, which went through a number of permutations and became the Dalla School of Public Health, came out of the history of the 1918 pandemic and some of the needs that were identified there. So these are challenging times, but they're also very interesting times for people that work in public health. So the focus today is going to be on science and policy making. And, we get very simplistic sorts of messages. Premier Ford said everything that they do is based on science and the advice that they get. And then back in the spring, we got asked who your scientists are, where you're getting the advice. But more significantly, those simplistic statements actually, why I think wind up hurting the cause of science, because science is not a perfect sort of thing. There's always disputes and disagreements in science. It's always evolving. And so we wind up seeing the criticisms, for example, on masking. People are changing their minds. Well, it's not actually they're changing their minds. The science and the knowledge base has been evolving over time. And so we have to be careful about what commitments we make from the science perspective and what the policymakers are saying about it. So just a few words, you'll get much more of this through your programs. What's sort of the traditional view of how science gets into policy? And the view is that there's a decision maker somewhere, usually in government, who's looking for an answer to a question. So they're trying to figure out which door they should go into. And there's a scientist out there with the answer to the question. And we can solve the challenges of the decision maker just by simply connecting the scientist to the decision maker. It's obviously not that simple, but a lot of concepts and terms around knowledge translation and so on are still based on this very simplistic linear model. A much more realistic view is first to acknowledge that there are barriers, there's walls between the research community and the policy community, and that decision makers, first of all, there is no hypothetical single decision maker. There are decision makers, and as we'll see again in the case of something like COVID-19, they're working at different levels of government, in and out of government, in the health sector, in the private sector, and they're being influenced by a range of different forces. And the media, what the public thinks, and what the polling is showing, and so on. And we can talk further in discussion about the forces that really drive decision making. So I'm just going to very quickly do a little bit of theory based on work that I've been involved in over, I hate to say now, over 25 years, but which has informed my thinking about how science and should really be thought of, and also how the policy process works for bringing in information for health decision making. So the first thing is really starting with, what do we mean by evidence? So Ross Upshur and I did some work almost 20 years, or over 20 years ago now, when we were part of something called the HealNet, the Health Evidence Applications Linkages Network, which was all about getting evidence into the health system at different levels. And it was launched around the time of the explosion of evidence-based medicine, and we got evidence-based policy, evidence-based nursing, and the list went on. There were books on every one of those topics. And that tradition grew out of a very important consideration, and that was, if we go back 40, 50 years, there wasn't a lot of science in medical decision-making. Things were based largely on expert opinion, on what the leadership, what the professor in a particular department would say. And so concepts of empirical science got brought into medicine to do experiments, to do trials, and so on. And that led to the development of the concepts around evidence-based medicine. It was very appropriate for certain types of decisions. If you're going to make a decision about what drug works best, a randomized controlled trial with blinding and all the other aspects to it is a really good way of getting the information you need for deciding on a particular treatment for a particular patient. And so that led to the development of things like the hierarchy of evidence, randomized controlled trials, cohort studies, case control studies, and so on, to inform that kind of clinical decision-making. When we got into the work with HealNet and we had groups that were looking at application of evidence in different levels of society, into policy making, into institutions, What became clear is, first of all, people didn't think of evidence in the same way across different parts of society, and the decisions that they were facing weren't the same. And what they were looking for to inform their decision making might not come from randomized trials. And so Ross developed this model that, again, I'll refer you to the paper, and the slides are certainly going to be available with all the references in them. But we had the spectrum from measurement, things that are based on very quantitative sorts of approach, to meaning, more qualitative, policy, historical document analysis, qualitative research, interviews, focus groups, and so on. And from things that focused on an individual to generalizing to a population. And so what we really framed was that the evidence-based medicine paradigm was based on this very mathematical, impersonal sort of approach. But if you want to make decisions for an individual, you also needed to have information about that individual. And if you wanted to really understand the context in which decisions are made, you needed to look at some of these things in the meaning quadrants. So I can't dive into this in more detail, but certainly refer you to the paper. And it's interesting, people continue to come back to these sorts of concepts. People continue to focus on, there's not randomized trials on masks, so we don't have good evidence. Whereas we may have evidence that's come from many different paradigms that informs our decision making. The next body of work was developed by Mark Dobro, who was a PhD student, would have been in the health policy program if it existed when he started, but some of you will probably encounter him as you work your way through IHPME as students. He did his thesis on a question that intrigued me. I was involved, as Rob noted in the introduction, in a number of different projects around cancer screening, and I was put onto different screening panels for prostate screening and cervical screening, colorectal screening, and I was finding that the decisions or recommendations that were getting made by the panels often didn't actually relate to the evidence base that existed. So as an example, prostate screening at the time back in the 90s had very weak evidence. There was really no evidence, yet people were pushing for the screening. And colorectal screening had very strong evidence from randomized trials. People were reluctant to adopt it. And what became clear was there are other forces, there were other contextual forces that were actually driving the recommendations of the panel. And so he did a very intensive set of case studies looking at the work of these cancer screening panels, interviewed the people who were on them, as well as document analysis, and developed two very important models. One is that decisions are really informed by context as well as evidence. What is the degree of evidence required? And in evidence-based medicine, you really focus in on evidence, and you don't pay as much attention, at least as it was framed at the time. I think in the intervening 15 or so years, the people who talk about this now talk in very different ways. And in fact, Brian Haynes, who's one of the people that helped coin the term, said, if he wanted to go back in time and change one thing, he would have said it should have been evidence-informed medicine as opposed to evidence-based medicine. But you pay less attention to context. What are the patient's values and so on? Whereas in political decision-making, politicians tend to be focused on a lot around what resources do I have? Who are the other players that might be affected by this decision? They're taking account of a lot more contextual factors, and they often, the joke is, they will look for the evidence to support the decision that they want to make. Evidence-based health policy tries to find a way in between, and ideally you want to get to a place where you're considering both the evidence and the context. Mark's view was we traditionally operate somewhere down here in the policy domain, not paying much attention to either and going with the political will or somewhere up here, but we want to move up into this quadrant. And then the other thing that he framed is really this question of how does context inform the use of evidence and based on these expert groups for cancer screening. And I think the really important conceptualization, and it goes back to that original linear model, is evidence doesn't come into the policy process in one magical moment. First of all, policy is a process, and evidence winds up being considered at several steps of the policy process. You've got to decide what you want to look for in terms of evidence, and how you look for it is going to drive which evidence you wind up seeing. How you interpret it. Do you apply the hierarchies of evidence? Do you value randomized trials over others? Do you value qualitative information, survey data, so on? And then, is it actually applied? And there's the context. In this case, the internal context would be the expert panel, who you put on there, what their backgrounds are, what their attitudes and values are, as well as the external context. Who's your report going to? Who's going to actually be making the policy decision? And then also identified these two very important things, that when we're looking to see what's evidence used in a decision, you can find some very formal sorts of processes, steps at which evidence is taken into account, and it's documented. But there's all sorts of informal, indirect things, the backroom conversations, so to speak. And that's often not as well documented. So the last study I'm going to talk about, and this is the one that was done by Laura Rosella, and she was a postdoctoral fellow, and in that first cohort of public health policy fellows, I guess well over 10 years ago now, right, Rob? And she had joined me as a postdoc actually to work on something completely different, just as H1N1 hit, and I was at Public Health Ontario. And amongst the projects she undertook, at that time, we were the science table for the Ministry of Health and the Chief Medical Officer of Health. And we had in real time the opportunity to actually study how the science that we were generating was flowing into the policy process. And Laura did a number of case studies. I won't read the sort of the key findings, but it basically confirmed the models that Mark had shown in play, as well as laid out a number of other issues around how things play out in an emergency situation versus the cancer screening, where you got lots of time, you're working off of a lot of research. And certainly many of the findings from this paper are still relevant to this day. And I went back and read it again sort of at the start of COVID-19 and thought, okay, we're going to live all of this once again. So I'm going to turn now to what's been happening in COVID. And you know, just to say, like, when we started back in February, March, before we really had the takeoff of cases in Canada, we were working with an unknown virus. And people could say you're basing your decisions on science, but it was important to acknowledge at that time, it was basically hypothesizing from earlier viruses, the experience with SARS-1, with MERS, as well as with respiratory viruses like influenza, what we should be doing. And so policies on masking and physical distance and stuff really being based on what people thought might be best based on experience from previous viruses. And to be perfectly blunt, when we got to the stage where we were entering into the exponential growth, in the absence of a vaccine or treatment for COVID-19, we were left working with the public health measures, the very blunt instruments that were imposed, for which there was incredibly little evidence base. The evidence base largely comes from 1918. The world was a very different place. It wasn't international air travel and so on. So to say that decisions were based on evidence is a little foolhardy. It was based on what people thought was best, based from the historical experiences that we'd had with similar or related viruses. We're now in a very different place, and we're starting to see an uptick, and maybe this will take us back into a second wave. But now we're in a place where there's been a lot of research done. And now, as I'm going to go through in the rest of the talk, we're in the different place of having probably too much evidence being generated all at once and trying to digest that and figure out how to implement that in policy. This slide lists a lot of the broader sort of changes in the world and society that have been underlying trends that have been looked at in many different contexts. But every one of these has also influenced how we've been able to respond to COVID-19 and many of them relate to how science is being used in the decision making. So, the first few around sort of changing global dynamic as well as our local dynamic in terms of politics, the perspectives that have been put in on the role of the WHO by different countries, the US-China tensions, the polarization, which has had an incredible effect on the United States. We've seen the inequities that have been revealed for people, and I think public health, population health always knew they were there, but I think for others, they've been revealed, but they've also influenced how we respond. So when we put out recommendations that people should isolate, if you're living in a multi-generational household, 8 people in a 3-bedroom or 2-bedroom apartment, telling someone to isolate and use your own washroom is not a very useful recommendation. And so we've learned, and now we're setting up isolation centers 6 or 8 months in. The labor market disruptions, the rise of the gig economy, things like CERB didn't work necessarily for Uber drivers. So a lot of these ongoing challenges out there have influenced how we've responded to and how we've been able to bring information into our decision making. Individuals want to have a much greater say. This leads to things like vaccine hesitancy, as well as social media. We no longer have a 6 o'clock news cycle. So when I started in public health, and even as late as H1N1 in 2009, the Ministry of Health still worked on a daily information cycle. You released your numbers at noon, you held your press conference at 3, and you commanded the 6 o'clock news. Now by the time you get to 6 o'clock, what you've said at 3 o'clock is irrelevant. So there's not the reporters, there's not the infrastructure in the media to actually digest all the information that's coming out. And then finally, I'll come back to this at the end. Within Canada, we continue to have underfunding. It's probably a global thing as well of public health. It's fragmented across levels of government. And I like to say the biggest threat for the health of Canadians is the Constitution Act. And again, we can come back to that. But by that, I mean the division of powers between the federal government and the provinces and territories leads to the varying decisions that get made across jurisdictions in the country. So a few words about science in the time of COVID. Not meant to read this. I did this slide back in June for another talk. At that time, this was all the funding programs in Canada that had been launched. And by June, we had $2 billion had been committed by the federal government to COVID-19 research. And to put that in perspective, $2 billion is the annual budget of the Canadian Institutes for Health Research for all health research. So one virus gets in 6 months as much as all health research. So it's a great thing. We're investing in research, but it means we've got a lot of stuff coming out. And I'll just say the other problem with the approach that was taken in the early stages was not very strategic. We're getting lots of different siloed programs with investigator-initiated research, and we have big questions left unaddressed that are still policy issues, and now government's scrambling to try to address them. And this funding and the intense activity in research was obviously followed by an explosion in research output. And there's one comment that the exponential, because this has actually continued since this slide was done, rate of growth of publications mirrors the rate of growth of the virus. So Right now, I think it's over 500 papers a day being published about COVID-19. So how does even an expert group keep up on top of all of that? The other thing, though, is this growth in preprints. And this is papers that people deposit as they're submitting, and so they're not yet peer-reviewed. I want to be clear, this is actually a really good thing, right? Having papers come out as preprints ensures that information is available in a timely manner and for other researchers to look at. It's a commitment to open science. But what we've seen during the time of COVID is attention being paid to individual preprints that are getting posted, often garnering major international headlines, pressure to influence policy, but people don't understand that that study's not yet peer-reviewed. It hasn't gone through the process and so on. And in fact, that policy shouldn't be made on an individual paper. We really need to be thinking about synthesis and how it fits together. And so I think that has presented another challenge to the use of evidence, because the science tables, the groups are often, if you listen to the press conferences that get held with the public health officials, they're often being asked about this latest preprint, and they're not going to know there's 500 things coming out a day. And the media are expecting them, well, why aren't you aware of this? And so it's confusing for the public, and it makes it look like our public health leaders are not informed about the latest science because everything's out in the public domain in this way. And even for the things that go through peer review and get published, we've had some very high profile retraction in major journals like the Lancet and New England Journal of Medicine. And I'm sure everyone's seen the news and seen Donald Trump talking about hydroxychloroquine, and the studies that really drove some of that initial thinking were very quickly retracted. And so that also influences the ability to incorporate science into this. The other thing is we've had an explosion not only of research and science, but now in Canada, we've had multiple task forces and different groups being struck. And there's the official group led by the Chief Public Health Officer and involves all the Chief Medical Officers of health across the country, which is meant to provide the science direction, receives input from a number of people. The federal government has now set up a number of task forces, and I'm on the immunity task force. And then the Office of the Chief Science Advisor, Mona Nemer, who advises the Prime Minister, has set up a number of expert panels of her own. And so, as was noted, CAN-COVID has just been established and is getting set up. And one of our roles is going to be to try to coordinate science activity across the country. The challenge now is that with all these different groups going, there's not crosstalk. So rather than bringing things together, not only is there all these individual research projects, there's now these individual silos. And we just this week, we had these three groups come together because the immunity task force very closely ties in with the work of the vaccine task force, as an example, in therapeutics and vaccines. So turning now to the issue of what's actually been happening in the public discourse and how it's influenced our science response. First thing I want to just comment on is what I refer to as the medicalization of the response to COVID-19. And I wrote a piece in The Conversation in the spring around this, that the title here refers to the point I made that everyone recognized the frontline healthcare workers. You're out there banging pots for them. No one ever talked about the people in public health. And in fact, in the picture here really demonstrated it. You saw in the United States that the lead spokesperson, until Donald Trump booted him out, was Anthony Fauci. I have great respect for him. He's a leader in infectious disease, both as a clinician and as a researcher. So Robert Redfield, the head of the Centers for Disease Control, in the first few months was essentially invisible. And the public health community was very much underrepresented in the US response. even in Canadian media, most of the commentary is provided by infectious disease specialists, clinicians, and much less by people coming from a public health background. And this leads to many biases in the responses that we have. And this paper that was published in the summer in JAMA highlighted several of them. Again, in the interest of time, I won't go through all of them, but just say that, again, a medicalized response focuses in on the ill cases, the people with COVID. We don't necessarily look at the broader consequences and the entire population. It looks at the individual people as that you can identify have disease, but if you have consequences for a broader population, but you can't identify them, they're statistical, they're less valued. There's a tendency for optimism that the cure's around the corner, we're going to end this very quickly, as opposed to planning for the worst. And again, what we're seeing in the news right now is a result of some of that, and I'll come back to that. Not worrying about the future. Again, back in the spring, when there were proposals for increasing lab testing capacity beyond what they were talking about, people weren't sure we may not need it in the fall. Let's just focus on the things now. So you focus on the present. And people don't make decisions because taking a decision that might lead to harm, even if it's smaller, is something that is preferred to making a decision that would wind up ending in failure. And so that's why we have delays. We had delays in March, and we might have seen in recent weeks with the uptick in cases. And the result of all these biases, we wind up with panic in the population, because what we wind up commuting out is not the longer term sort of scenario, but a focus on the immediate and visible, and leads to panic buying, and this is toilet paper being run out. So, what are some examples of the medicalization and sort of focus on the wrong things? Remember, China built hospitals. In the UK, National Health Service had this plan for these Nightingale hospitals. Even in Canada, we had, I think out in Burlington, field tents being deployed and so on. They all wound up being empty, right? Huge focus on that. Huge focus on getting ventilators. We had Nobel-winning physicists figuring out how to make ventilators because we thought they were going to be in short supply. And a focus on the wrong kinds of testing. So money was put in very early on into Spartan Bioscience for the point of care technology, which was at that time not even approved by Health Canada. I think $40 or $50 million was announced by the Prime Minister, and then it was withdrawn. So people tend to focus on immediate fixes, on the medical sorts of things, and what we miss out on are the investments in the core things that public health needed, having basic testing capacity, contact tracing, research on what was working and not working with public health measures to inform being ready for a fall wave. And then the other part of the medicalization, I would say, and the sort of focus on sort of magic or silver bullets has been this emphasis on a vaccine. I hope as much as anyone that we'll have a vaccine soon. And the recent results are promising. But the reality is a vaccine may not work perfectly. It may not work for some people. It may have side effects for some people. It may need multiple doses. We'll likely need to have several vaccines in our armamentarium. But even if we do get a vaccine approved by election day, as Donald Trump hopes, or early in 2021, the reality is to bring things under control and back to where we'd like to be, we have to get that vaccine, an effective vaccine, into 6 billion people. And anyone thinks that that's happening overnight is deluded. And that's why the WHO this week was talking about 2022 as the earliest that we're out of things. And so, again, the medicalization is focused on the immediate and has not really been communicating to the population how long this is going to really take. This was a piece that just came out earlier this week, and I thought was really, really important. That this is an Oxford epidemiologist who's come under intense personal attacks on social media and feels that her perspective on alternate ways of thinking are really being intimidated by these attacks that are coming from other academics. And so this is also, I think, underlying sort of the use of science, is that people are being almost suppressed in expressing different views. And the other thing that social media in particular, but the focus on headlines and the focus on immediate news cycles, is that it leads to what's been referred to as false dichotomies. In a paper that was posted last month, Isaac Bogosh from UHN is a co-author on this, that everyone wants things to be simply either or, and they go through these 5 case studies. It's either the health or the economy, as opposed to, there's nuances. It's spread out in between. And I'll walk through the examples on the method of spread, which has been very much in the news. So if back in early July, you might remember there was this open letter sent to the WHO by leading scientists that we need to think about airborne transmission and aerosol spread through ventilation and so on. At the same time, there was a very good summary published in JAMA that had actually said it's important to think about that, but it's not the dominant means of transmission. And then about a month later, equally stellar group of scientists wrote an open letter to the WHO and had it published in the same journal as this first one, saying, we disagree with this group. This is the normal hurly-burly of science, right? Where science is evolving, people play it out at conferences and debates and so on, but it's happening out in the open letters in the media and so on. And then we have these things like this letter in the New England Journal, which showed that the virus could survive for up to 72 hours on plastics. Huge emphasis through the media, and we still find reference to this. I was on Toronto Public Health document the other day, and they still refer to 72 hours. The authors of the paper actually acknowledge that they did not study a real life environment. And in July, a very good analysis of the original paper was published in JAMA. It has had some attention in the media, but nowhere near the attention that the first paper got. So people are still washing their groceries when they come through and so on. And the key problem was it was a very well-designed scientific study, but in an artificial lab environment, they deposited millions of times the normal virus into samples. It had the nutrients that the virus uses in the sample, and they measured how long it survived, which is the way in which those sorts of studies are done. It didn't examine how long the virus particles that are expelled from someone will survive on a surface, which, as it turns out, is a very short period of time, if at all. But those are things that are driving our science, our policy, and it's always the first one that gets the most attention, and the more recent public health response usually doesn't get as much attention. And my favorite, and you probably remember the thing about the joggers spreading the virus more than 6 meters. It was an aerodynamic engineer that did this hypothetical model. It was never published or peer-reviewed, and it's still referred to over and over again. And the original author actually says he never intended what he did to get the kind of attention. He was just showing something hypothetically, that this is the kind of modeling we should be doing on virus spread. So very quick thing about the normal distribution. So the thing about the false dichotomy is you want to have it either or, but things actually happen on a distribution. And so if we think about the modes of transmission of the virus, I'm almost done. Modes of transmission of the virus, it goes from maybe from the surface, maybe through these aerosols that can spread farther, but the dominant mode is the droplet spread, which requires close contact, right? And we got to think about the normal distribution. Now, what happens is when you're doing tens of thousands of papers and you're studying every outbreak as closely as they've been studied in COVID-19, you're going to find papers published right along the spectrum of how the virus spreads. And so the science is going to be there for whatever perspective you take. It's the synthesis of all that science that becomes important as opposed to looking at individual papers. Very quickly on the importance of a population health perspective, and I'm going to skip over some of these slides. I'm sure everyone is familiar or will become very familiar in their programs about population health. But we've learned a lot about who's at greatest risk, and it's revealed, as we always know, who winds up getting these sorts of diseases, and it's people who are essential workers and living in high density housing. And we've had the hotspot maps published. We also have if we take a population health perspective, we also have all the consequences of the population public health measures to think about. And again, I'm running out of time, so I'm not going to go through each of these in detail, but just highlight a couple of examples. This is the drop in emergency room visits in March compared to the previous year. An overall 25% decline. By the last week in March, when we were into full lockdown, half the people were going to emergency room as normally. And it was across all levels of acuity. So even people requiring resuscitation, people with heart attacks and strokes were not. What happened to them? Those are the statistical deaths that are not as visible as the COVID death. And when this came out from CIHI, there was a couple of pickups in the Canadian press and almost no media attention. I had thought that this would have been front page news. So we hear about the people who've had their procedures canceled. This paper looked at immunization visits being missed for kids. We're going to likely see outbreaks. Africa is looking at tremendous outbreaks of tuberculosis. Declines in physical activity, which is going to lead to poor health outcomes. Fitbit data. Increase in alcohol and drug use, been demonstrated across a number of studies now. Increases in mental health consequences. The impact on the younger generation. This is why there's so much focus on the reopening of schools and universities. And this is something really important to pay attention to. Canadian Civil Liberties Association put out this report on who got the most tickets for violations of the public health measures. It was people from low-income communities, it was visible minorities, it was racialized communities that were most likely to be ticketed. And we know with these new restrictions that have just been announced for parties and so on, it's not going to be people in Rosedale having a party with 40 people that will get tickets. It's going to be people out in Brampton that will be getting the tickets from the police. And so what have been the taking a population health perspective, how do we apply this? And some recent work that Laura Rosella and I are working on with Kevin Bryan, an economist at Rotman, is looking at the health impacts of the economic effects of the lockdown. And we'll be presenting this at the Health Economics Rounds in a couple of weeks, if anyone is interested in much more detail than this one slide. But just to say that we're estimating the number of higher cost health users, people are going to have chronic conditions develop, as well as the deaths that are attributable to the immediate lockdowns from back in March and April. And we get into 4,000 to 5,000 increased healthcare users, high healthcare users, as well as deaths. Just to close, there's no new lessons from my perspective in COVID-19. You can go back and read the SARS reports, and all the challenges that we faced are the same challenges that we faced then. And we've had stories come out about the things that got launched, like the GFIN network, Public Health Agency of Canada, that got cut, and then now it's being reinstated and reviewed. We still have all our problems with health data, Indigenous communities. We've had last year, Public Health Ontario had 30% budget cuts. So if we continue to have a medicalized focus, we wind up losing the capacity to generate the data, the science that's actually needed in these sorts of situations. And so I'll just close by saying, again, the recommendations are no different from those after SARS and H1N1. We have to continue to reinvest in population public health services and not cut when there's no outbreaks for a few years, which is exactly what happens every time. We need to look at the FPT model. It is broken. And we need a mechanism for, particularly for the science synthesis and the development recommendations, to be done in a way that there's a single national process that the provinces and territories agree to accepting. And it is done in other areas. And I think for, at least for emergency response, we need to do that. And we have to get information flowing, because you can't generate the evidence you need without data. And on the medical versus population health, really starting to think about holding people to account, including healthcare system leaders, hospital leaders, and so on, for health outcomes and not for clinical outputs. And then I think that will help push us towards a population health focus. So thanks. Sorry, I think I went about 5 minutes too long. Hope it's okay.
Thank you very much, Vivek, for a tremendous opening to our public health policy rounds, both conceptual overview of the role of evidence in policymaking in the area of health, and really amazing information about how much evidence of which sort is being developed and how it's being used. So very interesting perspective on the medicalization of the policymaking and what evidence is being considered. So I've got a bunch of questions of my own, but I'm going to hold them, and I'm going to ask our first discussant, Gregory Marshallton, to give his remarks for no more than 5 minutes. Thanks, Greg.
Thank you very much, and thank you, Vivek. That was very much a 6-course, what I would call a chef's special meal. It really captured so much of your own knowledge and experience and research over so many years, and you covered an enormous amount of ground, so thank you for that. And I want to start with sort of what you mean by evidence and how you laid it out, and the research that you've done with others on this in terms of the policy decision-making process. And you know, the old idea that, you know, you have different kinds of so-called evidence, but the idea that you have data is transformed into information, which in turn is transformed into analysis over time, and eventually, hopefully, knowledge and maybe even a bit of wisdom. But the kind of the central point here is the analysis, because the public health analysis feeds a decision-making process that is based upon policy analysis. So it is an input into the overall policy analysis, as you know. And that's often the problem in the sense that, and having dealt with decision makers extensively on this, there's 2 issues. One is that the what I'll call the public health analysis can be either overwhelming or, as you point out, contradictory at times. And at that point, decision makers are likely to throw up their hands in horror and walk away, or they will pick their favorite in terms of what they want, sort of how do they want to shape the outcome. And there's nothing much we can do about that, because science does evolve, and you just have to be very clear as to sort of the state of knowledge at that time, and provide a kind of a trajectory in terms of timelines as to when you think the evidence will begin to become clear to allow the analysis to become clear. But I think that's a major challenge. The other part of this, of course, is that the policy analysis has built into it so many factors, which you recognize, of course, because you are doing that analysis on employment in the economy. And that's sort of one sector. Another sector is sort of the welfare analysis in terms of the impact on people and survival in these circumstances, as well as a host of other factors. And that all goes into sort of, in a sense, the policy analysis, and then to figure out what the right interventions are in terms of what to do about this. That's where knowledge and wisdom come in. And I think it's very important for public health analysts to grapple with the issues that you've grappled with in terms of the policy decision-making process and in terms of this interaction between the two. Now, let me move to the challenge, to the COVID-19 response. And here, I'm going to try to provide a somewhat different perspective. I don't know if it's a challenge to what you said, perhaps it is, but this is the idea that the Constitution itself is the greatest threat to public health. And by that, of course, you talk about the division of powers. I'd like to present a somewhat different perspective on that issue, which is that we've actually benefited from having federations respond to this crisis where subnational governments have had some autonomy from the central government. If you look at the situation in Mexico, the United States, and Brazil, given the lack of what we would call responsible leadership at the national level, it has been up to the states to respond in a more effective way, and some of them indeed have, and it has saved many lives in the process. And so the difficulty with a highly centralized country is that if the central government lacks capacity or is doing all of the wrong things, this will affect the entire population because there's no buffer. But in a federation, and the more decentralized the federation, and the greater the decision-making that power within the subnational units, they can produce alternatives. And the beauty of a federation is that when one jurisdiction sees what's effective in another jurisdiction, they'll often copy it quite quickly, particularly when this is under the glare of the media. So there are advantages at times to a federation. We see this in Canada to some extent. When I look at the federal government, I don't see a government that's hampered by the Constitution. I see a government that has chosen to do certain things and, more importantly, not to do certain things. And I'll come back to that in a minute, but I see another jurisdiction, for example, like British Columbia, which has done many of the right things. And in that sense, is a more model jurisdiction than the central government and offers a path for other jurisdictions within the country. So that's in the case of Canada, but it has been absolutely lethal in places like Brazil and Mexico. And if they hadn't had a constitution and hadn't had a federation, it would have been an even worse disaster than it is already. So, but that said, I would say that the federal government could and should have done much more. There was nothing blocking it. Public health is actually shared jurisdiction. It's not within the exclusive jurisdiction of the provinces. You have to read the heads of power. It does offer the federal government plenty of opportunity. They chose not to exercise that opportunity. Second of all, the federal government has not used the spending power astutely in terms of ensuring through the transfer of money to the provinces that there would be better sharing of information and better control of that information by a clearing body at the national level. So we have faced enormous difficulties because of that, but that's not the Constitution. I think that is the federal government itself. And this is something that could have been corrected quite easily. The other aspect of that is on a much broader level. Every province invoked its emergency powers to deal with COVID-19. The federal government chose not to do so, when I think there were good grounds to do so, and there were things that the federal government could have done under the emergency powers to mitigate some of the problems that we faced in the COVID-19 crisis. So I'm less inclined to blame the Constitution, more inclined to place responsibility on the actions or inactions of government. So I throw that out, not in a way to be disputatious, but simply to maybe have a bit of a discussion, particularly with the students that are attending the session, to think about this particular issue. Thank you.
Thank you, Greg. And Vivek, I'm going to ask you to hold off. I'm sure you're like to respond right away, but I do want to get some others involved in the discussion. So I'm going to go to Daniel Eisencraft-Klein, our student discussant, and then Vivek, if you so choose, you can respond to the two discussants before we go to the Q&A. Daniel?
Thanks. Good afternoon, everyone. And thank you so much for your presentation, Dr. Goel, and the opportunity to speak here, Rob. So much of my own research and interests center around how policymakers' beliefs and values shape their policy formation. And you yourself, Dr. Goel, have pointed out previously that with 400 papers coming out a day on COVID, when a policymaker is saying that they are, quote, relying on the science, they themselves have to choose precisely which science. And then this decision-making process seems especially crucial given the context of what a recent Kennedy School report deemed the biggest test for policymakers in the public sector ever. So I thought actually this might be a useful segue to a broader conversation about the notions of, quote, evidence-based policymaking, even outside of science policies, as you were discussing, and especially given that growing recognition of policymakers bringing their own significant biases to the table, and that policymaking itself is not a hard science. I think in the Canadian context, it seemed increasingly clear that policymakers' beliefs around CERB, austerity measures, whether to implement a green recovery, the social determinants of health, even insight services right now, are partially based on evidence, but also are rooted heavily in policymakers' own values and principles. And then related to that, I've been working on a team at Western University on a systematic review on mathematical modeling of the COVID pandemic's trajectory and how the social determinants of health are either incorporated or not incorporated into those models. And one thing that we're finding in particular is that outside of their own personal interest in reducing social inequities, modelers don't see a lot of incentive to incorporating social determinants into their approaches. Generally, they're just focused on trying to get their models out there and put them out as quickly as possible. So to keep this brief, because I know we have somewhat limited time, I have two somewhat sticky questions, somewhat about science policy, but also more focused on social policy related to this. And this is also coming from being in this collaborative specialization and having the experience of trying to analyze policy, both as a rational model and as, you know, a bit of a garbage can model. So first is, how do we as policy analysts reconcile that data that shows policymakers are frequently deeply biased and susceptible to their own anecdotes or personal beliefs, while also hoping for some sorts of evidence-based or evidence-informed policymaking? And then second, especially in the context of the medicalized approach that you mentioned, and that policymakers are often among the most privileged people within society, do you have any thoughts on how we can better incentivize incorporation by decision makers of progressive policies, especially green recovery and ongoing combating of social inequities, into policy approaches when population-based policy analyses may be more attractive often? So I'm going to cut out a lot of what I was going to get at and just leave those for you, but thank you for taking the time to discuss this.
Thank you, Daniel. And Vivek, I think you need an opportunity now to respond. You have at least 3 cutting questions that you may want to respond to. You don't have to respond to them all.
Yeah. So maybe, first of all, I appreciate both sets of comments and observations. First of all, I don't think that what Greg and I are saying is necessarily different, because what I referred to is we need a national approach. I would not just leave it with the federal government to do. And so we need to think about, and particularly in an emergency situation like we have, how do we formulate our policy recommendations in a way that we get the best from across the country out on the table. And again, if you go back and look at the SARS, David Naylor's SARS report, and you look at what the original intent of how Public Health Agency Canada was to be structured, the Special Advisory Committee, which is the group the Public Health Agency of Canada has, with all the chief medical officers of health, that was supposed to be that sort of national structure that brought the provinces and territories with Public Health Agency of Canada. You know, it's been gummed up. I don't, you know, you can put all sorts of things to it, but the fact, because they don't get stuff out, so they released the guidance for post-secondary institutions at the beginning of August. Right? We're 3 weeks from the start of the term. And the Ontario still hasn't released its guidance for, and Toronto Public Health and Peel Public Health have released guidance. So we're dealing as a university operating in 2 health units with guidance from the federal government, vague stuff from the province, and 2 different health units. That's not a, to me, that's not a national approach. So, and in terms of the split of powers, you know, I think I'm not saying we need to go back and revise the Constitution. We need to take that into account and when we're making decisions. So we think about quarantine as a federal power. But when our students arrive and they're quarantined, the province will see anyone who's positive. And so then they're interested in what we're doing. And what I've observed over the last few months from my university role has been involved in this, is like there's no coordination between multiple federal departments that are involved in this: Immigration, Border Services, which is under Public Safety, Health Canada, Public Health Agency Canada. There's no coordination across all of them. And then the provincial level is the same thing. You got OPP that gets called in if someone's not monitored following quarantine. You got Ministry of Health, you got the local health departments. So, and everyone's role winds up being distributed based, you know, is this a provincial, is this a federal, and so on, based on the Constitution. So that's really what I was getting at. And I think there are tools that could be used to try to improve that. And I think your point about the analysis from public health being overwhelming and being, you know, contradictory, and part of that is because we get all these different things coming out. We get this health department, that health department. So again, if we can think about how that gets coordinated, and part of it is because of the hurly-burly of science and the evolution. And I think that's just leading, we need to help people understand. In terms of the Daniel's points, I think those are great points. I'm not sure I necessarily have answers to them in terms of, I think that's what research like yours and other fellows is going to be all about, is, you know, on the biases one, I think the important thing is making sure people are forced to be transparent on their biases and transparent on if they considered evidence and the science was clear in one direction, but they chose to go in another direction, they have to be forced to lay that out. And so one example that's in Laura's paper from H1N1 is on the mask issue, which is never goes away. It doesn't matter what the infectious disease, there will always be a debate about masks of some type. And in H1N1, it was, should N95s, respirators be used by healthcare workers on a routine basis. And when it was started as a new virus, it was recommended. And then once we saw that was a regular strain of influenza, we started to recommend dropping to the usual masking precautions. Every jurisdiction in the world, World Health Organization, CDC, the rest of Canada, went to surgical masks for H1N1. But Ontario, there was intense pressure coming particularly from the healthcare worker community because of the experience that Ontario had had with SARS of maintaining a higher level of protection, N95 masks. So we were asked at Public Health Ontario to write our scientific summary. We summarized the science, sent it over. And I'll remember the meeting with the deputy minister at the time was Ron Sapsford. He said to me, okay, we're, you know, in the political environment that we're in the negotiations with nursing unions and so on, we're going to stick with N95s for a while longer. Recognize your evidence. We know that that's what it says, but this is what our minister and cabinet want to do. And I said, fine, and we're going to put our report out publicly, and you're going to have to respond. And I remember being at a press conference with Dave Williams, who was the acting chief medical officer of health at the time, and he got asked, he said, here's the government's policy position. I got asked, that was the science, we submitted it. Government has made a considered decision, taking into account all the factors it has to take into account. So they had to lay it out. Unfortunately, that does not happen very often. And instead, what we wind up with, people are incorporating their biases into the decision, but then they'll say they based it on the science, and then we get into this debate if science is fuzzy and so on. And in terms of incentivizing a population health approach, and you touched on it with the green, I think as a society, there's some more fundamental things that we really need to think about is this present bias versus future bias, right? And we see it in health with prevention, and we see it in the environment. And so I don't think it's something that we can solve from within the health system. I think it's a much bigger thing. And I think, again, Greg and others that are on the call can speak to this, like election cycles. There's all these other things that drive politicians to the more immediate sorts of things, as opposed to taking that broader long-term perspective. And certainly taking a population health perspective means you're going to take that longer-term perspective.
Okay, thank you. I think that's a great start to inviting members of the Collaborative Specialization in Public Health Policy to ask questions. There are two I see in the chat now, three. So we're going to start with Diane S., who's curious about the Emergency Measures Act and how it played out with COVID. Dan, do you want to go on to the audio and just ask your question directly?
Yeah, no, some of my questions, I was just kind of curious opinions on whether or not you think that the Emergency Measures Act should have been enacted at the start of COVID. And I think just looking back on how different provinces, responded, looking at New Brunswick had a very strict lockdown, BC had very low cases to start with, and the different approaches. I'm wondering, is it something, do you think, that might be considered if a second wave is coming or not?
Okay, so Vivek and Greg and Daniel are welcome to respond as well.
I think Greg touched on this, that there were probably are powers that the federal government could have used in the Emergency Act that could have helped. I think you've touched on another important thing is that, again, what I'm driving at is like the federal government working with the provinces and territories could really help articulate clearly the approaches that should be taken, but you need local decision making because the distribution of cases has varied across the country and has varied over time in different provinces and even within regions of the province. So you don't want to have a situation with a single one-size-fits-all sort of thing. But we've also got the situation that now that every province is starting to develop its own risk-based system, red, green, yellow, and the criteria are different. And that winds up being confusing for the public. So, I think there could be better coordination around some of those sorts of things, and then give the flexibility of the provinces and local public health to adapt them to their local circumstances.
Okay,
if Greg wants to add on the
there are a bunch of questions. I'm going to read the ones from the chat. I see a couple of raised hands as well. I'll fit you in. And I'm just going to go in order, just to be fair. So I think that the next person is, sorry, one second, Jesse Klingler, you wanted to ask a question.
Yeah, thanks for your talk. This is more on like the information side of things, but over the summer I was like involved in a research project where we were talking to PSWs, and Vivek, what you were talking about is like the flow of information not really being present between like larger scientific groups, and this being like a problem with like the data synthesis. Like, what could the role of like librarians or medical librarians be in doing that? Because that seems like actually a really big problem that sort of stifles some of the research.
Yeah, so first of all, librarians have a tremendous role to play. And if you, Public Health Ontario, they put out a daily summary brief of the evidence, and it's run by their library group. If you go on the U of T library website, they've set up a set of tools for COVID monitoring. I think most of the bodies that are charged with the production of information have people with information management or library science type backgrounds now helping. In the CAN COVID project, we're working with the Masters of Health Informatics students to improve the processes by which the queries come in, and then the different evidence synthesis groups get tapped for pulling things together. So absolutely, there are many different roles out there that need to be brought in to bring sort of the evidence to light. And I think that would, having those kinds of structures also then helps ensure that when there are disagreements, it's very clear what the disagreements are over. I was at a talk the other day, but Jeremy Grimshaw from Ottawa was talking about it, out of Oxford, they've done systematic reviews on the benefits of masks, and then they've got policy papers published by two different groups at Oxford, reaching completely different conclusions, but they're both working with the same systematic review. And so what they're forced to do then is, okay, the evidence is summarized in the same way, but here's the content, here's the values that they're each applying to come up with the different recommendations.
It's really fascinating. I think we're seeing sort of policy making based on evidence on steroids here, and I've been involved in several exercises with tobacco. We've got lots of time and tons of material, and trying to figure out in different countries using the evidence in different ways. So, Nadia, I'm going to go to you now. Did you want to ask your question orally?
Sure. Well, first of all, thank you, Dr. Goel, for your presentation. So I'm just curious to know your thoughts about how do you see the role of civil society organizations on policy making? I don't want to be too specific on COVID because this is, something new that we are all learning, and I don't think there was, a civil society organized to deal with this. But what is actually your thoughts, and are they actually on the table when policy is being developed or not?
So, and I think it's important to think about emergency situations separate from routine policy. So I would say absolutely, my view is that policy shouldn't be developed without broad engagement and inclusion of all perspectives, and including, civil society organizations can often bring that perspective of different groups in the population to the policy process. I mean, how that happens, that's not something that the researchers or the scientific community will drive. That's the policy process has to figure out how to engage civil society organizations. I think in an emergency setting, it becomes more challenging when you've got to get the recommendation out the next day for what people should be doing. How you engage the broader community is a little bit more challenging. But for example, for decisions on, or for the recommendations on prioritizing of ventilators, and there was a major report put out on that. And now there's work on prioritizing of the vaccine. The groups that are charged with doing that, I know, are definitely looking at how they engage the broader community and a range of organizations. The other, I had the example of the report from the Canadian Civil Liberties Association. To me, that really highlights the importance of having organizations like that out there, appropriately supported, to keep tabs on what is happening. And I think the results from that report have been informing decision making, the things like how they've dealt with homeless populations, the isolation centers that are now being funded, have come out from the engagement of different organizations in the community. But you can't do it all overnight when you have to make decisions in an emergency. So it's a difficult balancing act.
You've got a Harman's hand do now.
Thanks, Dr. Goel, for that presentation, and for Dr. Marshallton and Daniel to chime in with some interesting aspects as well. I wanted to just go back to the idea of false dichotomy for a moment. So you presented how we may view things as certain dichotomy: wear a mask, don't wear a mask, health versus economy. And in my personal experience taking care of individuals who are quarantined at my house after travel, I found myself, when I went to go explain things like average incubation period, at that time we knew to be 5 to 6 days, quarantine length was 14 days. As soon as I started nuancing things, I felt, these were my grandparents in this scenario, by the way, they just got a lot more confused with what I was saying. So I wondered if you could speak to whether for the public or general public, is it helpful to use false dichotomies in the argument for the precautionary principle, for example? So if we think, or if the evidence says, and this is just an example, masks are 70% effective or whatever, is it still worth making that dichotomy, making it dichotomous and saying wear a mask, and that be a policy question? So could you speak a little bit about that?
Yeah. So two things there. One is that the paper that I referred to is really talking about not making those false dichotomies in the scientific debate. And so within the research community, we should well be able to talk about the nuances and so on. But as with that Oxford social media example, like even in the research community, we're getting into people communicating by tweets and saying this is what it should be and or not be. And the letter writing campaigns that were going globally were driving a false dichotomy from the research community. So that's what that paper is really getting at, is we need to have more thorough debates amongst ourselves. You're getting at, okay, how do you communicate that to the public? And so I think there's, again, I think one is thinking about how the media, and if we're presenting to the media, we should be always clear about the ranges and so on. But to the point that you're getting at, wear a mask in public where it's recommended or required. Yeah, that's a simple statement, and I think making that is very clear. You don't need to get into it only works, and it's not that it's 70%. If you get 70% of people wearing a mask, it's going to drop the community transmission enough to help you in controlling, right? So I don't think you need to get into, with your grandparents, for example, trying to explain all those nuances. I think being able to tell them what they should be doing. But I think what happens, because we don't debate the false dichotomies as scientists, is we wind amongst ourselves, we wind up having those debates in the media, and that's confusing people, right? Because they don't get clear direction anymore.
So I do want to say we still have a number of questions, and we have about 8 minutes left. So we'll get to as many of them as we possibly can. I'm going to go to Victoria, who's had her hand raised, and then we're going to go back to the chat and just go in order. Maybe we'll raise a few questions at once and ask the panelists to pick and choose. But let's first go to Victoria.
So thank you so much, everyone, for giving this very enlightening discussion, a very relevant discussion. I'm wondering if you could speak a bit more about population health's role in preventing the transmission of COVID within long-term care homes and what happened.
So again, I think on that, if we actually take a longer-term perspective, what I would say the population health view should really bring to the discussion is, why are we putting people in these homes, right? So if we were really taking a population health perspective, we would be thinking about what are our models for care of the elderly or support of the elderly, because it shouldn't even be a care model, for keeping people in their homes, in their communities. And so I would say that everything we saw there is the result of a medicalized approach to supporting our older population. So it's not about COVID. I think it's really about how do we decide, how do we allocate resources for community, for social supports. And every time I've looked at this, it's less about the medical care that people need. It's about the supports that they have to be able to stay and age in place. And then for the people that do need to be in such a facility, how do we ensure that it is adequately resourced and staffed and so on? So that's what, in my mind, and going back to what I said at the very end, like if health systems were actually incented for the outcomes for the entire population, they would think about how much money is being put into long-term care and how much money is being put into home care and other social services. But they're not incented in that way, and the hospital is incented by how many people they get through the doors every day, by and large across the country. I don't know if Greg wants to add on that, because I know he's thought about this one.
Well, I'll just focus on the second part because you asked about the population health approach, but from a policy approach, you have to ask yourself, why has there been such a concentration of deaths in long-term care homes relative to other OECD countries? Canada is right at the sort of extreme end. It's an outlier. And when you look at that, there are two issues that pop out. We need considerable study to determine if these hypotheses are correct, but one is that in the face of public demand that outstripped supply, private homes began to fill that gap very quickly in the last 10 to 15 years. And these private homes weren't properly regulated, properly staffed, et cetera. So there's been a concentration of deaths in the private homes as opposed to the public homes. Second of all, you have an issue of the growing morbidity of these patients, both in terms of physical and cognitive disability, and the lack of sort of keeping up in terms of the physical infrastructure and the staff, and compared to other OECD countries, and the incredible responsibility that we, placed on the managers and the staff of these homes, and the very low salaries and wages that are paid these people, and the low level of education and training relative to other countries. So that clearly had an impact. There are stories of workers simply refusing to go back into the homes at a certain point, leaving them unstaffed because their risk was too great and they're paid so little. Why would they take that kind of risk on? Second of all, the lack of sort of identification and loyalty to the home, in part because of the way they're treated over time. So these are hypotheses that need to be tested. These aren't facts, but we really need to look at this sector much more closely than we have. It's been an area that we have ignored as policymakers in this country for a long time.
Thank you.
Thank you both. Vivek, I don't know if you're able to scroll through the chat, and or you'd prefer that I'd read out a couple of more questions.
I can just maybe pick a few of them. I guess we just have a couple of minutes left, right?
Yeah, pick one or two that you'd like to address. That'd be great.
So maybe I'll pick one from Shamiha on the spike in the 20 to 29-year-olds, because that's obviously in the news and probably relevant to many of our fellows. So there's a number of explanations for this, right? And first is that we increased testing capacity. So back in the spring, if you were younger and didn't have comorbidities, if you went into an assessment center, you might be declined anyway, even if you had symptoms, and just told to go isolate. But then as testing capacity became more available and case counts went down, everyone was getting tested. So we just were testing more in the younger population. Second is it's the younger people. As the economy started to reopen in July and August, those are jobs. When you actually look at the jobs that were lost in the spring, you know, older people like myself and others who were able to work from home kept their jobs. It was younger people were the ones, and people from minority populations were the ones that got displaced the most. And so they're the ones that started to come back in. And then, you know, I think then there's this explanation, which is the one that the media keeps going up. The younger people are interacting more and maybe less careful. You know, I don't think there's actually as much data to support that as the anecdotes that the media describes, but it's probably a contribution. So again, with all of these things, there's always a lot of things that are going into it. There's a question about the wearing of masks and the mixed messaging in the States. I would say, and we talked about it, we had mixed messaging in Canada as well, but, and I think this speaks to Greg's point that, you know, it was able to be turned around with clear messaging from the provinces and local public health. Interestingly, Ontario chose not to do something, whereas Quebec did, and Ontario left it to municipalities to do bylaws. And I was amazed by how that actually almost switched in a matter of weeks. Every municipality in Ontario passed its own bylaw in the absence of provincial. So I think it does speak to that you can get some things done, you can change the public perception. And Peter Lewin at the School of Public Policy has done some very interesting polling on this and points out that Canadians actually didn't even wait for the public messaging to completely change. The use of masks started to increase in Canada, and there was an organic sort of approach to that. So there's probably got to be something more fundamental between the United States and Canada about why they've not been able to get their masking up. And maybe the Rachel Lee's question about the academic culture, there's a lot, it's a long question, but absolutely I would say the incentive system and the sort of culture of academics has driven, and it leads people to want to get their publications and so on out faster. And it also doesn't necessarily incent people to take part in the consensus processes, the evidence synthesis tables. We've got lots of people doing that, and lots of people do it, but it's not something that is always valued as much. And I think, again, if we're really going to get to that evidence-based policy making, we need to think about those incentives for the academics as well. We'll stop there.
Vivek, thank you so very much. It's been quite a rapid fire of questions, and there's more that I'm sorry haven't been answered. I want to thank Vivek and Greg and Daniel for helping open up this first round. I want to thank all of the people who participated, either orally or through the chat. I apologize for not being able to get to all of the questions in this round. Stay tuned. Our next rounds in October are with Natasha Crowcroft, who will be joining us from Geneva. She's now based at the World Health Organization, also maintains her adjunct professor role at the Delaware School of Public Health. Thank you all from the Collaborative Specialization who have been so good about staying on even after we've started at 11 o'clock. So it's been a long late morning and early afternoon. Really important insights. I've learned a lot. I didn't get answers to my own questions either, but that's okay. We'll continue the process of inquiry, and in the Collaborative Specialization we'll have lots of opportunities to discuss many of these concepts further. Those of us who are not in the Collaborative Specialization who have joined us, thank you for joining, and please stay tuned and watch out for our notices of further events. If you do want to receive those notices, you can email publichealthpolicy@utoronto.ca, publichealthpolicy@utoronto.ca, and sign yourself up to be on our list.